Hey, oh, Martin.
Hello?
Hey, Martin, how you doing? Can you hear me okay? Hey, oh, Martin. Can anybody hear me?
I can hear you.
Okay, good. How you doing, Martin?
Hello? I'm fine.
How you doing?
Yeah, I'm fine.
Okay, can you hear me okay? That's a recording that I asked you.
Sorry, 1 minute.
Oh, great, great.
Right.
Hey, thank you for coming.
Yes, you're welcome. Most welcome.
Well, I should have communicated better. I should
Oh, it
have,
was.
I should have let you
Okay.
know. But you should have been receiving emails every day because you're on the email list. Did you get the emails that notified you of the webcast?
Well, I do get those. Yes, yes, I do get
And
those.
and you
Yes.
didn't see a beautiful face?
Well, no, eventually I did.
It's all over the place.
All right. So we're gonna have to speak Chinese now today.
Okay.
I'll teach you how to say hello to everybody.
Oh,
You have
okay.
to say da chao.
Cat's out.
How? Da chao how?
Cat's
Da
out.
cha
How?
how? Yes.
Cat's
Da cha how?
how?
Yes.
Cat's a how?
Da cha how?
That's a how.
How is good, okay?
Okay.
And I think the root of cha is something like home. And everybody is like the big home, like da cha, it's like it becomes everybody somehow. Yeah. So I'm just looking here. Where's my screen sharing sort of?
Yeah, you want to test
here.
it? You want to test
the
it
green
out?
one then.
Yeah,
Is
we
it
have 10 minutes. You can test it if you want.
Okay, let's see what it does. So if I go here, then it shares this. And I have to go to presentation mode here.
Right, exactly. At the bottom, it should be at the bottom. You have
doing it.
used the Apple, right?
Let's see, like that, right?
No, that's not large enough. It's going to be larger. Yeah, at the far left corner, you see the far left.
Oh,
at the bottom.
On the Zoom,
No, on your program,
Right? Yeah, but
okay. You see the slide on the left, brief anatomy.
I see it. I see it full screen right now.
Below. Test that now. Below, at the far left, there's three options. There's 3 options to press.
Optimize the video clip, share the sound. Let's see again.
It's at the far left. Below that slide, brief anatomy review on the left. Yeah. You see that little slide on the left at the bottom? It's below that on the left. It's below that. There you go. One of those. Yeah, try them all.
Slide short viewer.
Try them all.
Slideshow. This one.
Okay, there you go. There you go. And
okay.
To go forward, you go right on the slide, and backwards, left.
Yeah. So did it go backwards now? Or is it going?
Go ahead. Go back. Click it on the left side of the screen.
Unfortunately, somehow here it doesn't work exactly like that, but
okay,
it doesn't matter. So what happens if I do this?
Oh, you shouldn't have to do that. Resume charge. You should be able to stay on the same. Try it. Let's try it again. Go onto the big screen. Go on the far left.
What do you see now? You see a calendar?
No. no, that's not the right screen. You gotta put the big screen. You gotta.
Like that.
Okay, no. At the far left, at the bottom, you gotta make it a big screen.
Yeah, here.
Yeah, go ahead. Go ahead. Click it.
Yeah, I clicked it.
Nothing happened. We'll click something else and
New screening sharing is paused. Okay, so I should not do that.
what you had it before.
What's coming here? Let's see if I share this.
Try the other. There you go. You got it. You got it. Okay, now click on the right side. The slide should go forward. If you go to the right side of that screen and click.
I'm already on full screen here. Let's
Okay,
see.
there may be other options. You move it forward.
Stop share.
But on the right side, the right bottom, go to the right bottom of the screen.
But this is actually a movie which I want to show here.
I don't see it. I don't see it there.
You
Go
don't
to the
see it.
right bottom. This is something I know works. But I can't do it if you don't listen. Go to the bottom right and click.
Right.
Bottom right and click.
Okay. What about it now?
No.
Let me get out of this screen sharing
But
here.
you play around with it. At the bottom there's a forward.
I know that's in PowerPoint, you mean, right? I did that, but I can't find that in movies, unfortunately.
Okay, just play with it a little bit. Play with it.
Okay, sure. Can you hear me, John?
Yeah, well, let me see. Let me check. Okay, you want to try it again?
Well, I did it the way you told me. Is it not showing anything now? Your screen
Yeah,
sharing is
okay. Yeah, there's no screen sharing there.
resume share.
Okay, now do you have Apple or,
I have Windows.
okay, you see at the bottom of the screen, there's a forward sign. You see that on the bottom left of your screen, you see there's a icon that
In
lets
in
you,
in which application? In the Zoom application?
no, in your application, look at the bottom
I-
of the screen when you move your cursor down. You see that icon that pops out? If you click on that, you'll probably go forward. You see, move your cursor down to the bottom.
Yes. On the very left.
No, you're not at the
Yeah.
bottom. You're at the middle. At the bottom. Move your cursor to the bottom.
Okay. So here.
It's not at the bottom. It's in the middle.
Can you see my cursor?
I can see it. No, I can't. Yeah, I can see it. It's in the middle of the screen as far as what I see.
Oh, okay, well then, but I'm at the bottom with the cursor here.
Oh, you are? Okay. Okay, well, do whatever you feel comfortable with. If you want to just go at slide by slide, that's fine too.
No, but here we have slideshow and should not be like that. It is slideshow. So this doesn't show you the slideshow? Full screen?
Yeah, okay. Okay. Let's start again. Get off. Okay, I'm gonna kick you off, okay?
Okay, kick me.
And you start again. Okay, go to share screen.
Okay. Now I can share two screens here.
Okay.
I can share PowerPoint, or I can show the video which I halted, but I can just let it run. So
No, let's do
the
no,
video
let's do
I'm
the
gonna let it run later. Yeah. So you want me to go to PowerPoint?
PowerPoint. Go to PowerPoint.
Okay, I'm going to PowerPoint and I click on the blue one here.
Yeah, okay.
Hold Control to select multiple windows, but I'm not gonna do that.
No, you want to make
I just do share now.
Yeah, exactly.
Now you got PowerPoint.
Okay. You can just use that screen if you want, and everyone.
No, but look, if I do what you told me before, this lower left. Now I click it.
Yeah, do what you need to
Coming
do.
a slideshow now.
Okay.
So is that not slideshow?
But you don't seem to learn how to do it. You can't. It's not working. I mean, that's not a slideshow. I see.
Okay, what do you see?
If you can connect the other options at the bottom.
Yeah.
Other options. You may find it. Find out which one of those gives you a. No, it's one of the three options. You keep going everywhere, but there. The three options.
Here.
Right there.
There's normal view.
Okay.
There's normal view.
Okay.
There's slide sorter view, which we
Okay,
don't want.
Okay,
Slideshow.
Okay, go slideshow.
Yeah. And then it gives me that.
Okay, now you got the slideshow, right?
Yes.
Well, that doesn't work, so go back.
Okay. So do you see anything now? Do you just see the normal part?
I see your
See
screen.
the PowerPoint view.
I see the PowerPoint, and if you want to do, you can just click on to move the slide. You just do it manually, like, you know what I mean? Click on that, and then when you're ready to move, click on the next one. That'll make it simpler. Okay.
Okay, like this.
Yeah, that'll make it simpler. Okay, and do it that way because that's easier to understand. Okay.
Okay. But the slideshow, I get it on my screen except it doesn't seem to be picked up by Zoom, and I don't understand why.
Yeah, I
We
don't,
have
yeah, let's do this for now, okay?
Yeah,
And you could just stay on there. I'll introduce you, okay?
sure.
Just give me a second. And actually, I'm gonna get you off the screen to,
Sure.
and you just have to go back. Okay, I'll introduce you.
Sure.
Okay, there's a welcome, Syed, Anita, Christos, Hassan, Jose, Casual. Okay, Martin, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach, home of Neurosurgical TV. Today, we have the honor of having Martin Woodtli. He's a neurosurgeon from Switzerland, currently practicing in Dubai. And Martin's a frequent visitor to these webcasts. He really seems to enjoy it. He always adds something to the webcast by asking questions, etc. So welcome, Martin. It's all yours.
Well, thanks for welcoming me. I just want to briefly introduce. So I trained in Switzerland amongst Probst and Yashagil, and later on I went to New Zealand. I did a skull-based fellowship in Toronto, and then I worked in Switzerland with my colleague and former boss Denis Kach, and we did some spinal work at the time. Although my training was more in cerebrovascular and skull-based, we did some of that. So I'm going to share the screen now. Let's see whether it works. Can you see it now?
Yes, it's okay.
Okay. That's how for all those who speak Chinese. And so I am presently working I used to work for 3 years in Rashid Hospital in Dubai, and now I moved to another hospital called Sarah Hospital. But this work here, a lot of stuff which we did in Switzerland, and we presented some of that in meetings at the WFNS, and some of it was published. And so let me get right into it. Now. Okay, has it changed, John? Has the picture changed?
Yes, it has.
Yeah. Okay, so what I'm going to talk about is you know, something that nobody seems to be paying attention to, is that the lumbar root actually has several segments, and they have all sorts of names. There's a lot of terminology problems in lumbar disc surgery, in spinal surgery altogether. So here I have a proposal to call these root segments similarly like we call the arteries of the cerebral arteries. We call them M1, M2, M3, etc. So here we have those, and I will now step by step lead you up to why and what the clinical significance of this could be. So terminology is important, and as the Chinese philosopher and great master Confucius said, if you want to talk about something, you have to give it the right name. So just to clarify a little bit of basic anatomy, because often people don't understand what's going on in my talks. So we have, of course, the lamina, and we have the transverse process, the superior articular process, and the inferior one. And in between, there is this bridge, and it has been called pars interarticularis, which is a bit of a long name, but it also has been called, because it's kind of a narrowing there, it's called the isthmus. So when we do approaches to the extraforaminal space, we actually have to open up this here. So the upper lateral quadrant of the facet joint on the inferior side and along the transverse process, and we get to the root and the ganglion. And similarly, inside we have to open here the bone to open the lateral recess. This is a projection of the pedicular root. So what we're talking about when we mean isthmus is this area here. Everybody knows it from spondylolysis, and it is this corner here which is of great interest in approaching these nerve roots from the outside. Here's a picture of a lumbar vertebra, but it's an upper lumbar vertebra. So you see that here, this corner, this isthmic arch, as we could call it, is actually very medial. So in these, to approach a nerve root extraforaminally is quite easy. Not much needs to be done. So the approach is, as many of you know, with the endoscope and the microscope to the different levels of the lumbar spine. They're all a little bit different. Plus that there's different degrees of degenerative changes. Plus that I feel that the lumbar vertebrae, maybe somebody should do a study about it. They're a little bit like faces of people, or everybody has nose and eyes, but they're all looking a little bit different. So here's a side view, which I just want to point out that if you look at the inferior articular process, it is much farther away from the anchoring pedicle as opposed to the superior one. And that is why this bridge here is of enormous importance to stability. It also levers the posterior tension band between the spinous processes. And that's also why it breaks in spondylolysis and listhesis and in some trauma. So, okay, so that's the kind of oblique view everybody knows, with the little dog that has a collar here. So here it is, a picture. So anyway, that was just some introductory remark about the isthmus. And so let's talk about radicular pain. So Mixter and Barr in 1931, they observed that lumbar discs actually cause radicular pain. Then the whole story evolved, that it was then found that it wasn't only discs, but it was also spinal stenosis, which causes intermittent claudication, intermittent pain, has relatively simple radiology, and then it evolved. And a lot of people kind of missed out on McNabb, 1971. He's actually a rheumatologist from Toronto, and he described 5 places. Here they are. I will not get into too much detail, but I will show you pictures. By the way, I will make this presentation available for anybody. I will put my email address in the chat box, and anybody can download it. So here are those 5 places where the nerve root can also be impinged. So it can be inside the foramen. Everybody has heard about intraforaminal hernias. They come from outside and migrate a little bit up. Then there's this called a pedicular kinking. We will get to that. It is when the pedicle moves down relative, and it is usually because of height loss here in the disc that is inferior to that lesion. It is something that is radiologically a little bit difficult to identify, but during surgery you can always check what is the tension on the nerve root once you have decompressed in this area here, and you use a hook and you find it is still tensioned, and you can drill off this edge here of the pedicle to release that. Then there's also a impingement by an osteophyte formation together with phlegm in the foramen here. There's another foraminal impingement. And then, of course, there's the lateral recess, which everybody knows. Here it is basically beneath the superior facet joint and lateral going towards the pedicle, and then there's the extraforaminal hernia. So so then we actually in 1997 we saw that, you know, there can be these multiple entrapments and multi-level lesions like that. So as one single approach doesn't do, so we gave a presentation about combined approaches, and it is always worthwhile to keep in mind that any decompressive steps will be enhanced by thinking about that the lumbar nerve roots can be entrapped as well as stretched, which is equally important, in more than one segment between the exit from the dural sac to the postganglionic zone. So we try to introduce some kind of ABC scheme, which of course people back then didn't really understand very much about what we're talking about. And I quickly realized when giving presentations, but anyway, that's what we propose. And here is actually, at the time I was in Toronto, and as I said, my teaching was in skull base. I was a skull base fellow there with Dr. Gentili, who recently passed away. And it was interesting because we did a lot of drilling in the skull base. And so in the spine, obviously, you can do also very sophisticated drilling. Actually, Dr. Gentili, at the time when I told him about these things, he said, he said a bit glib, well, we don't need this. We have an operation, and he said we just do a laminectomy. Okay, we'll get back to that idea. That was so back then. So we, as I said, you know, the basic fenestration is either medial or lateral, and then you can combine it. So if you combine it, you do a medial and a lateral one. If you do it, you might decompress two nerve roots, one above and the one below, or you might decompress a kind of a double cross. So here's a summary of all these. So medial and lateral concerning two nerve roots, medial and lateral concerning one nerve root.
Excuse me, Martin.
Yeah.
I don't know why, but the slides seem cloudy for some. Do they look cloudy to you?
No,
How about the other panelists? Does it look cloudy to you? The slide?
Yes, it is cloudy.
Yeah. Can you? Is there something you can do to make it less cloudy? Like maybe reboot or something, or change slide? You know what I mean? You're not seeing the cloudiness. Right, Martin?
I see it very clearly here. Let me go to the next slide. Maybe this is.
Yeah.
Do you see this clear now?
Yeah, but it's still cloudy.
Really? Oh dear.
I wonder if we'll have it. That's okay. We'll get through it.
All right. Well, anyway, let's keep on talking about.
Let's keep on going. Okay.
Yeah.
Okay.
So so pain, you know, radicular pain is often, you know, described as nerve root encroachment, entrapment. It means that people think about compression, but nerve root compression actually leads to diminished perfusion and axonal flow. So it primarily results in numbness and weakness. Whereas nerve root tensioning may be an idea that is a bit less favored, as I mean, you get it when the dentist pulls on your tooth or something. So in the lumbar nerve root, you can manifest it by doing a straight leg raising test, and it is commonly underestimated by the surgeons when we do the surgery, but it is there. And of course, there's also the influence of inflammatory pathways. But there's something else as well, which people kind of underestimate, and it's pseudoradicular pain. It is a referred pain, like the head zones that we get from abdominal organs projecting somewhere. and it is underdiagnosed, and it responds to facet joint infiltration and anti-inflammatory measures. And here's the reason why it happens. You can, I don't know, is this cloudy again? Here's the nerve root exiting, and it has a ventral nerve root, and it has a dorsal nerve root going to the muscle here, and to the facet joint, and to the interspinous ligament. And so if that one is irritated mostly by facet joint processes, then the pain up in the head kind of projects a little bit odd into the leg, namely in this fashion here, and it never really goes much below the knee level. But this pain has nothing to do with the nerve root compression or tensioning, and it is distinct, and it is more of a facet joint problem. So facet joints do have degenerative changes always, because the mechanical stress when the disc degenerates and we have disc hernias is quite unequal on them, so they do go into degeneration. So that leads us to the question of lower back pain. So it's activated obviously by osteoarthritic processes like the one. Then there's this important annular tear syndrome before a disc hernia of the subligamentous or epidural kind occurs. You know, the annulus of the disc has to rupture, and that causes a lot of pain. It's very acute pain that these patients have, and that responds to anti-inflammatory drugs. And then there's sagittal balance, which is worth a whole lecture of its own, and that is related to evolving deformity, and it's a big issue in planning fusions. So then lastly, we have this lower back pain in instability or spinal instability, as we see it, for example, in spondylolisthesis and spondylolysis, and it is not to be confused with degenerative deformity processes, and it is a good indication for a monosegmental fusion. Patients do extremely well immediately after the surgery. How do you diagnose it? It's all clinical signs. It's an instability catch. The patient tries to catch his thigh when he's trying to get from bent position into upright position. They sometimes have a instability giveaway, like all joints that are not stable have this giveaway feeling. The knee does have that, and the back as well. The pain is usually when they go up from a bent position, and on functional x-rays we see shifts more than 4 millimeters. And of course, long term there is progressive listhesis. So the problem with a lot of the back surgery really lies in properly clinically diagnosing things. And if that is not done, and the surgery was maybe not the one the patient needed, we get these failed back surgery syndromes. So briefly, here's some reasons why they occur: insufficient decompression, because maybe it was not realized that the nerve is somewhere else compressed; recurrence, of course; instability after decompression. If you do laminectomies, you disrupt the tension band, the posterior one, and possibly also this isthmic bridge. And so then that leads to instability and would need a fusion. Periradicular scars can be quite annoying. And then these atypical nerve root entrapments that McNabb described, and overall insufficient identification of the clinical syndrome and untreated sagittal balance. This is a big thing now. People sometimes end up having a fusion in a bad position, which only worsens their back pain. So let's get back to the nerve roots. So basically we have these classical hernias, the stenosis, and the extraforaminal hernias. And over the years, different things have been proposed for the extraforaminal hernia. There used to be something like a transmuscular approach. That kind of went out of fashion. And now with endoscopy, which is aiming at the foramen, it is probably not being done by anybody. But the TLIF was always also an answer to some foraminal impingement because it is also going there. So this whole thing started with a very small technical note by Dr. Chain from South Carolina, who was many years was the editor of the Journal of Neurosurgery. And it was really just a one-page technical note. And here are some of his drawings, which I modified. And he is now advocating here to go to the extraforaminal space from a midline incision. And so that was Jane. And then the key concept is that you can reach the extraforaminal space through a midline incision. And the transmuscular route can be avoided, and access to the intraforaminal space is possible. And then, so then came our idea, okay, why don't we combine this also with medial decompressions of the lateral recess zone here. And then, like I said in the ancient presentation from Amsterdam, we proposed this and we published this. And then what is important is that we keep at least 5 millimeters of isthmic bridge. And this was kind of a rule of thumb by a French spinal surgeon, Camille Roy, or Roy Camille, that this is enough to prevent any listhesis or any subluxation in the future. And here it is again. So this isthmic bridge here needs to be preserved. So we did back then, we just did a kind of a feasibility study with only 52 patients. And basically we still had, by the way, 75 residual slight sensory loss after 1 year, residual weakness, M5 minus if you check carefully, and 40% of them still had episodes of lower back pain, but they mostly returned to work. So the most common extraforaminal pathology in elderly in stenosis is actually this impingement syndrome of the cranial facet joint process here. This area is inside the foramen when the patient reclines, is pinging on the nerve and leads to an intermittent pain. So we discovered that it is possible through this approach to also remove this part of the inferior facet joint apex. And then somehow after the year 2000 and a lot of spinal fusion went wrong because of different reasons, people started to get more interested again in minimally invasive procedures for stenosis. And so the idea came that we can actually drill over the top here and go to the other side. And I will show, hopefully with the little video I have, how this is being done. Then lastly, we also discovered that probably it's a good idea to do kind of with the drill a 360-degree decompression of nerve roots. And I'm sure that the evolving endoscopic practice will also pick up on that idea. So then if you combine all of this, you get all sorts of, like, they're kind of minimally invasive as compared to just, you know, like doing a laminectomy and doing a fusion everywhere. You get all these different patterns with over the top decompressions, lateral, medial, etc. So one thing I often get asked by my colleagues is how big is it really need to be? And I would say an impingement at the critical site can be as small as 3 millimeters, and that's enough. at the right place, but you have to be able to identify that during the surgery, and you have to have a good idea of the anatomy before you go there. And actually lesions without a proper buttress dressing against it, they tend to be disappointments in surgery. They can look quite big on MRI, but since they're not really squeezing or tensioning the nerve root, they don't lead to good results. So T-lifts are best for monosegmental instability, and it was always an alternative for extraforaminal pathology, because you actually just remove everything, and then you have to fuse it to prevent the instability problems. But people started to get a little bit less invasive over the years. So here is my advocacy for using the drills. You can see here that the drill is a cutting drill, and you can use it for the superior lamina, because there's going to be phlavum beneath it. And when you get inferiorly, where there's not going to be any phlavum over the lateral recess, you have to use a diamond drill. And that is perfectly possible. And you have to preserve this isthmic bridge. Like I said, I don't think this is very good picture showing it, but and then if you rotate the patient, you can actually now cross the midline here in this angle and go all the way to the other side. So drills are very helpful for precise fashioning, and there's no microfracturing. And you can reach and remove bones in areas where you wouldn't get to just with a punch. But and when you use the endoscope, this also becomes very important. So what we've learned is that these 360-degree compressions of a nerve root are actually very useful. And endoscopic techniques are evolving, but so far it seems to me that they're best in more focal pathologies. And it is always important that to study precisely where the pain is coming from, which segment, which root, etc. And fusions may or may not be necessary for its own reasons, stability preservation, sagittal balance reasons. But sagittal balance, to be corrected, actually needs osteotomies. And a lot of people are still doing fusions without that, and I'm not so sure how helpful that is. One of the problems in all of this surgery has always been descriptions for decompressive maneuvers have been kind of loose. Laminectomy, hemilaminectomy, fenestrations, and different authors mean different things with different operative extent. This adds to the confusion. If you want to have success, you really have to distinguish between true radicular pain, which is constant or intermittent in spinal claudication, and pseudoradicular pain coming from the facet joint, and all sorts of mechanically triggered things which have to do with spondyloarthritis, and then all these disturbances that come from evolving deformity. So since there is actually a thing like multi-segment root entrapment, there have been many different terms proposed for these segments of the roots. And so it brings me back to this slide, which I showed you in the beginning, that we could call them R0, which is for disc hernias which migrate in a cranial direction from the disc level, the classic one at the disc level, R1, the one into the lateral recess that everybody knows, recessal, R3, around the pedicle. When it comes to pedicular kinking here, that's when you find the nerve root is still tensioned, even though you decompressed all of this. And then the foraminal one and extraforaminal one. So here's a few examples. Here is an example of an R0. It is here displaced superiorly from the disc level, and it looks like that. It goes up to the level of the lateral recess of the upper segment. So sometimes if these are very big and cannot be pulled down, you can open the lateral recess one level above, in this example at L4-5, and you will get amazingly better control over this free epidural fragment here. So that would be the R0 compression. And then we have the one that everybody knows, the disc hernia at the level of the disc, and it looks like this. And not too much comment about that at the R1 level. And then in the lateral recess, now it's migrated inferiorly, and it looks like that. And you can see here the particular root, and it's right here. And so you have to, this part of the facet joint here needs to be removed. This is actually the superior articular process of the inferior vertebra, which forms this root. I will show this hopefully if the video, if I can get it going. So that would be the R2 segment. Then here we have something around the pedicle, which is here. This is actually best seen how much root tensioning there is during the surgery. Then we have R4. R3 is a little bit of a thing, you know, there is no clear radiological findings. So maybe better coronal views can show it. That would be the only way of demonstrating it. Because as you see here in this drawing, what happens is the disc below the lesion has lost height, and so the pedicle here impinges on the root in this R3 segment. So you have to make room for it here, and the only solution is to take the drill and just flatten out this a little bit, and then the root will be relieved. And then we have R4. This is an intraforaminal hernia, and you can see here how the superior articular process kind of narrowed the foramen, and if this patient reclines, it will pinch on the nerve root. And finally, that's R4, and finally we have the foraminal fragment, which is here. So you see this big fragment here, because this is not the nerve root. This is the ganglion obliquely, but here the ganglion is displaced more laterally. Right. So here is, you know, an example of a double cross where you have at L4, L5 this recessal, and there is also a foraminal component to it. And then here is an example of a triple cross. I won't get into it too much. So anyway, in conclusion, we see that multi-level disc disease is complicated in terms of surgical therapy, and clear naming of the possible nerve root segments might help in the planning, and clarifies complications also if you want to do studies of what happens to these various types of patients. So to end with Kung Fu, what you hear is what you forget, what you see is what you remember, and what you do is what you understand. So I want to conclude with that, and if there is a possibility, I'd like to show a video how this is being done. So can you see this?
No, cannot see it at all. It's not even cloudy.
Again.
Yeah, no, I don't even see the whole screen. You don't even see it. So you have to change the mode, I think. to what you had
Okay.
before.
Okay, so I make a new share.
Okay.
Now I want to share this. Is it showing now?
No, there it is, showing now.
Showing now.
Technical points.
Yeah, okay. So here's an example. I'll have to stop it from time to time because it's quite fast. So you can see here. So the isthmus is exposed here, and so is the midline, and this is the superior lamina, and that the inferior lamina and the interlaminar space in this case is very small. And here is this isthmus, and so now we're going to drill this with a sharp drill. So we can do this because there's going to be flavum here. So we do this. And now you should see the ligamentum flavum there. And now this here is the gap of the facet joint. So remember, this is the inferior articular process of the superior vertebra. And as I remove it, there's going to be the superior part of the articular process. And this bit of bone here is going to be the roof of the lateral recess. And the facet joint gap, at least at the level L4, L5, is usually at the disc level. So that's the gap there. So now down there, we need to be a little bit more careful because there's no flavum, otherwise you suddenly get a hole in the dura. So eventually we need to use, and now here, you can see this isthmic arch. And if you were to do a drilling, so this way here is superior and this is inferior. So if you wanted to approach the extraforaminal space, you would have to start drilling here. And then you get down to the ganglion, which is down there. But then I think in this case here, this is not being done. So it needs to be about 5 millimeters there. So here we are deroofing the lateral recess, and then we leave a little bit of bone and use a diamond drill. Here the dura is exposed now, and the flavum is exposed up here. And now we rotate the patient and we turn our attention to the other side. Now, with the endoscope, you can basically, if you understand this anatomy very well, you can do the same thing, also using a drill. I'm not so sure how it would work if you have to do more than one level, but I guess it could come through different punctures, and I'm sure endoscopy will evolve. So people will start to do all sorts of things. So what you see here is the flavum is now exposed on the left side of the patient, and on the right side. This here represented the midline. I know these pictures are not as beautiful as what you get when you do an intracranial surgery, some tumor with a subarachnoid space or something, but that's also the problem of endoscopy here. You're not gonna see as nicely as you would in other places. So now this was the inferior edge of the dura, so below it is going to be inferior edge of the flavum, sorry, and below it is going to be the dura mater. And so you can drill from one side and even expose the other. You can expose the disc on the other side if you want. So now the lateral recess is exposed on both sides. I think people have difficulty in understanding this video here, so it's because it's a bit quick, but anyhow, here it is. So now over here you see this little bony rim. So that's the rest of the lateral recess roof, and the pedicle is about here, and so you can also open up this exit roof zone there. And here you see this is the pedicular wall, and then up here or down here rather, and down here is the disc on the other side. So so only after we finished all this drilling are we going to remove the ligamentum flavum, and we mobilize it, and we remove it in one big piece. And here is this kind of drilling here. You see, here is where the nerve root exits on the left side, and it is impinged here. So if you drill down here, that's what's going to relieve this pedicular kinking. And so what this material here is facet joint capsule. So this is disc level, and you can see here this shiny stuff is from the facet joint gap, the cartilage. So you can properly decompress the root on the other side. And here we're removing the flavum. And I think that should be the end of the video soon. So I hope, right. Okay, so I'm going to stop here, and if there are any questions or comments, and please go ahead.
Okay, thank you very much, Martin, for spending all the time. Okay.
Okay.
Questions from the panelists. Harshad, we'll start off with you. How are you doing, Harshad?
Hi, John. I'm doing very well. Fine. Thank you. How are you?
Good.
Good. Yes, Professor Martin, excellent technique you have shown, and very nice representation of the root right from the root origin of the root from the dura to the foramen, and a root, complete extraforaminal. Wonderful anatomy you have shown, although the slides were a little fuzzy, but yes, we could make out what you are showing. There are a couple of things I would like to know from you. What is your view on a pain is unilateral?
Right.
And you don't see any disc material which is herniating out, but there is a facetal hypertrophy,
Yes.
which may be irritating the root. What do you
Yes.
advise to this kind of patients? That is the one thing.
It's a very good question, because ultimately all these decisions are clinical decisions, and that's where radiology can only sort of help us in trying to support our clinical decision. If you say that pain is on one side and it is intermittent, and it really is clearly provocable by reclination, for example, so then I would suspect there is a foraminal impingement with this facet joint hypertrophy that you said the patient has. So that would be one way of attacking it. If that is really, maybe you can evidence it on the MRI. You should see that the foramen on that one side is narrower as compared to the other side. And we don't do so much dynamic MRIs. There was a phase where we did dynamic MRIs, but they were not that, they didn't show us that much more. But obviously, you know, if that would be the way to demonstrate it for sure. So reclination provoking the pain, kind of a spinal claudication when walking, as opposed to bending, would point towards this being a foraminal impingement, I guess.
Do you decompress on both sides or one side always?
No, I'm a firm believer in only crossing the bridges which are needed to cross, because the more we do, the more we might also disturb things. And that is maybe the beauty of this endoscopic movement. Though having done a little bit endoscopic work, I must say, the tendency there is that you probably end up doing a little bit not enough. You know, you really have to, if you decide to decompress the nerve root, you should really do it enough. That is this whole idea about 360 degree, you know, like if there is an osteophyte beneath the lumbar nerve root at the disc level, then displace the nerve root and then take a drill and drill it away, you know, so that there is zero tension when you leave the operative field. And in endoscopy, you're a little bit hampered. It is so far, but I'm sure people will get much better with it, and they will do a lot of amazing work through more minimal approach. I mean, just with puncture. So
Now,
to
when
answer
the-
your question, I don't do any preventive steps actually.
Yeah.
Yes.
Okay, thank you. And when the laterally placed disc herniated, how much disc you remove? You remove the full disc, or you just remove the herniated part?
Yes, this is also a very good question. Often these laterally herniated discs are actually in the elder generation, we find them, and they are often covered by an osteophyte. So what I do is I drill away that osteophyte. That then opens the disc space, similar to what you get when you do a T-lift, where you could introduce your banana cage sort of thing. And I can roger out whatever material comes, you know. I'm not, you know, if say it was a very young patient, then, and it's a free fragment, okay, so you might only take the fragment. The trouble with that is also what we found in this study 25 years ago. The extraforaminal hernias, the pure ones, they tend to have more recurrence. Why is that? Because there's still some disc material around in the area which eventually degenerates and gets squeezed out once again. So I have abandoned this idea where, you know, people had there was a movement for a while, let's only remove the fragment. I feel like if we make the decision to go in, let's take the fragment, and also what could come out of that hole. There's got to be a hole in the disc for material to come out. So to clean that out as well. Yeah. So to answer your question is, I remove the hernia, drill off any osteophyte, and also take interdiscal material in the area as much as possible.
Okay, very good. I see.
Thank you, thank you, thank you.
You're welcome. You're welcome, Dr. Hassan.
Yeah, thank you, Harshad. Juan Lee has arrived. I'd like to welcome him. He's a cerebral vascular surgeon from Thien Ton Hospital, and he is going to host. Welcome, Juan Lee.
Hi, yeah, I'm here. I just I'm listening in class. I was driving, but now I'm at home. That's okay. Yeah.
Okay, any more comments, questions? I think someone else had one in the panel here. Let me get it. Causal, Deep, do you want to ask the question directly to Martin Causal, or you want me to ask it? Okay, I'll ask it. I think it's a statement from Karshal Deep. Okay, endoscopic interlaminar surgery can address three levels from the same 8 millimeter incision, including contralateral decompression.
Yeah.
Okay,
I'm sure some people can do that. I'm sure you can do it. It's a little bit the same. But for the upper level and the lower level, you get an angle of access which makes you work definitely harder, but possible. And so you really need to have sufficient experienced with all of this before embarking on that. So you better do a simple case first, you know.
Okay, any more comments, questions from anybody?
So I'll put my email address in the chat.
Yeah, go ahead, put it in now. So
And
yeah,
yeah.
put it in so make sure we get it.
So those who are interested in this, just send me an email and I will send you this presentation. You can have a look at it and modify it. I'm not saying this is final, but I think it will. People who work with the endoscope, they're interested in that type of thing. So here it is.
There's one more comment here. You said in the presentation that perhaps multiple incisions are required. Are required in endoscopic surgery. I was just making the point clear that this can be done from single incision.
Yeah. Well, I mean, I'm not sure if you do L2, L3 on the left side and then also L4, L5, something on the right side. So then I'm not so sure whether that can be done from one side. But yes, I agree. You know, you can do 3 levels if you do over the top with the endoscope.
Okay, very good. Okay, Woodtli, I'll turn it over to you to introduce the Chinese presenter. Can you do that, Woodtli?
Okay, yeah. Thank you again, Martin.
Yes,
yeah.
Yes.
Yeah, well, welcome to China again.
I taught John how to say hello to everybody. That's a how.
Yeah.
I forgot. I'm sorry.
Thank you.
I'll study it.
Okay.
Thank you again. Yeah. Now we move to the next speaker tonight, Dr. Chao Fan Zeng. She's a young neurosurgeon from our Beijing Tiantan Hospital, Capital Medical University, China. Now she will introduce some her molecular pathological study on the Moyamoya disease, especially the RNF213 mutation. So yeah, Dr. Zeng, please.
Thank you, Professor Zhao.
Yeah, do you want to put it on presentation mode? It's not full screen yet.
Oh, sorry.
That's it's at the bottom right-hand side, the very bottom. There's a bunch of options. There you go. You got it.
Oh, sorry.
Go back and go back again. You fell back.
Hey.
Oh, fell off. Don't worry. Take your time. Okay, now
So is
full
this
screen.
working?
At the very bottom on the right-hand side, there's a bunch of options. Yeah, there you go. In that area is the correct icon, the bottom right. You don't see that option? Can someone help him, Woodtli? Can you help him, please?
Yeah, actually, yeah. 那个超凡，你就点一下那再往右一个键，那个全屏，就这个。对。Yes.
Oh, sorry. Just 1 moment, sorry.
Okay.
Where's the mouse?
Yeah, John, I think it. I don't know whether something has changed on Zoom, but it used to be much easier to do the screen sharing.
Really? There's a change?
I don't know.
Oh, there you go,
so-
there you go, there you
yeah.
go.
现在可以了，
嗯
你就接着讲吧。OK，it's OK。
Okay. Sorry for. I'm Chao Fenzong. I'm a neurosurgical resident and a PhD student from a Department of Neurosurgery, Beijing Tianhe Hospital. I'm great honor to have this opportunity to share my research. And my topic is RNF213 variants and periventricular anastomosis in Moyamoya disease, a genotype phenotype association study. And I will introduce my research from the following 5 parts. Firstly, I will make a introduction of Moyamoya disease. As we know, Moyamoya disease is a chronic cerebrovascular disease characterized by progressive narrowing of the distal ICA and their proximal branches with abnormal collateral vessels. And according to humans, the spatial distribution of Moyamoya vessels can be classified as the ethmoidal Moyamoya, vault Moyamoya, and Moyamoya vessels in the basal ganglion thalamus. The distinctive narrowing of the distal ICA and their branches can be observed in the directional and histological features. For epidemiological features, Moyamoya disease was more common in East Asia countries such as Japan, Korea, and China. The annual incidence of MMD was 1.14 per 10,000 inhabitants in China. Age at onset characterized as a bimodal pattern, and the disease manifests with TIA or cerebral infarction or hemorrhage and asymptomatic. The disease can be diagnosed by DSA, MRI, CTA, and high-resolution MRI, etc. There are 2 main pathophysiology features, including the thickening, intima, and thin media of stenosed arteries, and the second is extension or dilation of collateral vessels. Until now, the pathogenesis of MMD remains unclear. The genetics, immunology, and hemodynamics may act as the potential pathogenic factors. Several susceptibility genes, including RNF213, MTHFR, DAF1, etc., have been identified in Moyamoya disease. RNF213 is the major susceptibility gene in East Asia. Our previous study showed that about 30% of MMD in China had PR4810K variant. Patients carrying PR4810K characterized by the disease early onset and high cumulative risk of stroke. However, in the genome editing animal models, the typical Moyamoya vessels were not observed, so the role of RNF213 remains unknown. A periventricular anastomosis is a pathophysiology anastomosis between perforating or choroidal arteries and medullary arteries in the periventricular region. Professor Takahashi firstly described the angiography features of anastomosis between perforating arteries and medullary arteries in 1980. Then Professor Funaki summarized the vessels in 2016. He classified 3 groups of PA vessels, including lenticular straight arteries, thalamic arteries, and choroidal arteries. We can see the typical PA vessels in the periventricular regions in Moyamoya disease patients compared with normal controls. From the pathophysiological perspective, is the formation of PA vessels refers to angiogenesis or arteriogenesis. Angiogenesis is the growth of capillary from pre-existing vessels. It is the sprouting of endothelial cells. Usually the initial trigger is hypoxia, while the arteriogenesis is the growth of collaterals proceeds by remodeling of pre-existing arterioles. It is induced after the stenosis or occlusion of a major artery. The initial trigger is fluid shear stress caused by altered blood flow through pre-existing collaterals. We consider that the pathophysiology of PA vessels is kind of arteriogenesis. The 3 degrees of collateral circulation can be classified into 3 grades. Grade 1 refers to the circulation via circovillus. Grade 2 refers to the circulation via leptomeningeal collateral, and grade 3 refers to the circulation via extended or dilated arteriogenesis. There are several evaluation standards of PA vessels according to the previous study. The PA vessels are classified as the extended and dilated arteries beyond a specific level. In our center, DSA was used to evaluate the level of PA vessels. Grade 0 referred to no dilation or extension. Grade 1 referred to the dilated or extended arteries reached the level of lateral ventricle. And grade 2 referred to the arteries beyond the level of lateral ventricle. A PA has been identified as the significant indicator for clinical manifestation like intracranial hemorrhage and prognosis or pathogenesis. Early in 2003, anterior carotid artery have been approved to be correlated with the clinical manifestation of hemorrhage. And there are several famous clinical trials of Moyamoya disease regarding the PA vessels, including the GEM trial, which is a multi-center cohort study of adult MMD in Japan. Our research team registered a single-center cohort study of MMD in Beijing Tianhe Hospital, conducting the study of RNF213 variants and collateral vessels in Moyamoya disease. The GEM trial summarized several types of the hemorrhagic manifestations, such as anterior or posterior types according to the spatial pattern. Consequently, the GEM trial proposed a PA score, which is the sum of the grade of 3 anastomosis groups. The study concluded that a higher PA score is a significant risk factor for hemorrhage. A PA is associated with spatial distribution of recurrent hemorrhage from anterior to posterior of the brain. The dilated and extended LSA, THA, and CHA was correlated with the spatial pattern of the hemorrhage. Our research team also conducted a retrospective study of hemorrhagic Moyamoya disease. We evaluated the angiographic features of PA vessels and explored the association of PA and hemorrhagic patterns. The spatial patterns are classified into anterior and posterior hemorrhage. We concluded that dilated CHA was observed to be significantly associated with increased risk of posterior hemorrhage. In that study, posterior CHA was significantly associated with recurrent hemorrhage. The same team further divided the potential anastomosis sites of LSA, THA, and CHA into medial medullary artery anastomosis, lateral medullary artery anastomosis, and non-medullary artery anastomosis. They concluded that medial medullary anastomosis is associated with ipsilateral recurrent hemorrhage. A previous Japanese study compared the participants of GEM trial and AMOR trial, which is a famous symptomatic Moyamoya disease cohort, The study found that a significant difference of PA vessels in hemorrhagic and asymptomatic patients. According to the study regarding the operative prognosis, patients with posterior hemorrhage benefit from the direct revascularization. The regression of anterior CHA can decrease the risk of recurrent hemorrhage after the EDAS in pediatric hemorrhagic Moyamoya disease. Well, the direct revascularization are able to change the proportion of PA vessels. In general, PA vessels can predict hemorrhage or recurrent hemorrhage and optimize the surgical strategy and evaluate the prognosis. There are several research progression of PA vessels. This study found that LSA decreased with age and posterior communication artery and posterior CHA increased with age. They proposed a theory that PA transfers from anterior to posterior with age. A previous study of Xuanwu Hospital, they analyzed the angiographic features of LSA and performed the three-dimensional reconstruction. They found that the total length of LSA is associated with anterior hemorrhage in MMD. The high-resolution vessel wall MRI has been used for the differential diagnosis and quantitative evaluation. The recent study figured that the enhancement sign of PA is associated with hemorrhage. Also, the spatial pattern of parentracheal anastomosis in the cortex has been established by three-dimensional MRI. The dilated LSA is connected to the anterior and medial cortex, while the dilated CHA was connected to the posterior cortex. A previous study compared interethnic difference of PA on the prevalence of hemorrhage in Japanese and Caucasians MMD patients, and significantly dilated CHA was found in Japanese than in Caucasians. So was the difference proportion of dilated PA vessels related to the genetics? This brings us to the next question. What's the genetic background associated with PA vessels in Chinese? As we know, the genetic background of MMD patients is different from Caucasians or East Asians. RNF213 is a higher prevalence in East Asia. Therefore, we aim to explore the association of RNF213 variants and parentracheal anastomosis in the MMD cohort. We recruited eligible patients from the MMD cohort registered on the clinical trial. Finally, 260 patients were included. Patients were grouped according to the RNF213 variants, and group 1 referred to 185 patients carrying no variants, and group 2 referred to 52 patients carrying PR4810K variant, and group 3 refers to 23 patients carrying other rare and novel variants of RNF213. Peripheral blood were selected and Sanger sequencing was performed. The E3 module, including exon 42 to 68 in the C terminal of RNF213 was sequenced. The C terminal was sequenced. A total of 22 missense variants were identified, and there were 7 highly conserved regions. We then compared the distribution of PA among 3 groups. There were significant differences of each PA in patients with RNF213 variants. A higher distribution of dilated PA vessels and PA score were identified in patients carrying RNF213 variants. We then now analyzed the variables associated with PA score in the various logistic regression model, PR4810K and other variants were identified as the strongest variable associated with a positive PA score. Besides Suzuki stage equal or greater than 4, and PCA involvement were also significantly associated with a positive PA score, while age and platelet count were associated with a negative PA score. Due to the difficulty of specimen acquirement, we analyzed the gene expression in the normal human brain using the public database of Allen Brain Atlas and BrainNet in the second part of our study. The Allen Brain Atlas consists of 6 subjects, a total of over 1,000 anatomical locations were classified. We can identify the location and the expression of each gene in human genome. The BrainNet database consists of 134 subjects and 10 regions of the brain. In the analysis of expression of RNF213 in the normal brain using Allen Brain Atlas, we have found that the expression of RNF213 was specific in different brain regions. Increased expression of RNF213 was identified in the basal ganglia, thalamus, and the midbrain, while decreased expression was identified in the cortex. Similarly, using BrainNet database, the expression of RNF213 in deep white matter and the medulla was significantly higher than in the occipital, frontal, or temporal cortex. So the increased expression of RNF213 was identified in the parentracular region. In the discussion from the embryological perspective in normal brain, centripetal and centrifugal models of the white matter blood supply system was formed, and the arteries from ACA supplied the white matter from outside to inside. And there were some arteries like LSA, THA, and CHA supplied the deep white matter from inside to outside. Professor Moody firstly reported 6 patterns of blood supply from the white matter. This offers us a new perspective to investigate the pathogenesis of dilated PA vessels in Moyamoya disease. In general, we first identified that the extent of PA was associated with the RNF213 variants. Patients with PR4810K and other variants had higher PA score. The degree of PA was correlated with RNF213 variants in the clinical association analysis. Then we conducted a genotype-phenotype mechanism exploration of RNF213 expression in the brain. Higher expression in parentracular region and lower expression in cerebral cortex of RNF213 was observed. Therefore, we concluded that RNF213 involves in the process of arteriogenesis in MMD. There are few prospects regard to the study. With the progression of multi-omics technology, radiomics, transcriptomics has become increasingly concerned. The spatial pattern of genes at the single cell level in the neurological diseases can be identified, which will help to investigate the pathogenesis, especially in Moyamoya disease with no specimen of the primary pathogenic site. Another prospect is the quantitatively evaluation of Moyamoya vessels, like dilated vessels in the parentracular region can be segmented, reconstructed, and evaluated using 3-dimensional DSA or 7-Tesla MRI, etc., which will help to understand the pathogenesis and the relations of PA vessels and brain structures. That's all. Thank you for listening.
Okay, Woodtli.
Okay, thank you. Yes, thank you, Dr. Zeng. As we know, Moyamoya disease is kind of intracranial artery stenosis, mostly for the young population. It's quite common and popular disease in East Asian country, but maybe not so common in Western country. So yeah, Dr. Zeng, in our hospital, we have a big group to do a series of Moyamoya disease, both surgical treatment and also the basic research. So yeah, are there any questions about this topic?
Martin?
I have, yeah, I
Um,
have a very simple question actually. What is RFN 213? What does it stand for?
Well, it's a name of a gene, like a ring, really interesting protein 213. It's a name actually.
Yeah, but the abbreviation has a history, know where it came from, but
RNF.
yes.
So you want to know why
It's an acronym, you know, it's an abbreviation. So what is this abbreviation? Where does it come from?
So you want to know the abbreviation of RNF13?
Yeah. Is there a meaning behind this, or is this just like an algebraic number, or what's the story?
Oh, actually, RNF is it's called the ring. No, it's yeah, it's ring finger protein, 213. It's a kind of a sensitive gene for the Moyamoya disease, and founded by a Japanese neurosurgeon.
Okay.
Yeah, ring finger protein 213. Yeah. It's
Okay,
like kind of like the IDH mutation for glioma. Yeah.
But IDH means isodehydrogenase, so you know, so
Yeah.
we know what that is. But anyway, I was just wondering what.
Yeah, yeah. RNF means ring finger protein.
Yeah. Okay, thank you.
This is a question, really, I'm not a neurosurgeon. It's a question about genomics. Is doing genetic testing common in neurosurgery patients, Woodtli? Is it common in testing, doing genetic profiles and things, or it's rare?
Yeah, actually,
yeah.
I think it's quite common. Yeah, we always want to find some special gene or protein mutation for some special disease, especially some like a rare disease. Yeah, Dr. Zeng, maybe you can give more comprehensive explanation.
Yeah, thank you for your question. Actually, we usually perform the RNF213 sequencing for all of our MMD patients, and also we found that there are several familial MMD cohorts, like their parents, they carrying the variant, and their children, they may also carry that variant. So it's really important for their children, and they may have a early onset of the disease, which is a quite important for indicate for the prognosis or the indication for the surgical strategy. Yeah.
So if you have a patient that has a negative history of, say, a brain tumor and has no supposed genetic defects, do you do a screen anyways, just to pick up any genetic defects, or unless it's a reason to, you don't do the genetic testing?
Mm,
I'm just talking about
Well,
a regular patient that comes in with a tumor. Any kind.
like
Are they
like
tested for genetically, or that's only done in special cases?
you mean for tumor patients?
Yeah, any tumor patient, yeah.
Well, maybe it depends on the different types of the tumors,
Oh,
like
okay.
glioma or glioblastoma. Well, it's totally different. According,
Okay.
yeah, it's not it's different from Moyamoya disease. We collect the blood samples and do the sequencing. Well, for gliomas, they often collect the tissue samples in the surgery, and they do the sequence like a high dimensional sequencing or RNA sequencing. Well, they can test the primary pathogenic site. So it's different from the DNA sequencing.
Thank you.
Thank you for your question.
Any role of genomic sequencing in management of Moyamoya disease? Does it alter in any way, or it is just a study?
I think RNF213 kind of have a strong relation with some and Moyamoya disease patient with genetic. I mean, and the family and family tendency. Like in Japan, Korea, and there are many such kind of research. There are maybe 80 and 90% of the Moyamoya disease patient with family history, and they have this kind of the genetic mutation. But in China, I think we are still collecting more patients for more large sample research.
So basically, it's a research thing rather than a treatment planning.
What? For
Yeah,
plan?
but we are looking at a research point of view rather than a treatment planning by this. The methodology for the treatment of Moyamoya does not alter by this research.
Yeah, Dr. Zeng, can you answer this question?
Yeah, I see. So we routinely do the sequencing. Well, it will not the surgical strategy will not alter by the sequencing result, but the result can be a important indicator for the prognosis. And according to the previous literature, and if patients carrying a PR4810K variant, and they will have a high ability to have a post-operative angiogenesis of the Moyamoya vessels after the surgery. And well, patients carrying no variant, they are more they will have a lower ability to grow their Moyamoya vessels in the parenchymal regions. So it's quite important to know the surgical well, it's important for the prognosis, and also for the pediatric patients. Once they carrying the variant, they have a high level of cumulative risk of stroke during their lifetime. So it's very important for us.
Yes, thank you.
I have one question also. Do you know what is the inheritance pattern of this genomic abnormality? Is it, and do you know which chromosome it is located? And does it need to come from only one parent, or do you know anything about that?
Yes, it's from some 17, and once a patient carrying zygous variant,
Yes.
well, they have a GA variant, and they have a variant from one parent. Well, there are less common cases of AA genome, and they carrying double A, and the double A come from both parents. So their parents carrying the same GA genotype.
So in other words, it has to come from both parents to be expressed.
Yeah, sure.
And okay, so is there any, are you doing any genetic counseling in these cases? Meaning that you advise them not to have children, or maybe to screen a partner for future children of the affected patient?
Well, actually, we often don't give the specific recommendation of if they have children or do not have children. It's quite it's not that far yet. Well, if we can tell them if they have a variant, their children may carry the possibility of their children carry the variant, and once their children have tested and found a variant, they may have a high cumulative risk of stroke, and even the incidence of the disease. Yeah.
Right. Okay.
Hey,
Thank you.
good. Very good. I'd like to say hello to Salam to Ahmad Fawad Prada from Afghanistan. Good day. Good day, Ahmad. Are you there? Okay, I guess maybe away. Okay, very good. Okay, excellent presentation. Sheofan, thank you for taking the time to help teach us. And thank you, Harshad, Martin, and of course, Wan Lee for moderating. And we'll see you guys in 2 weeks. Have a good day. Well, by the way, okay, I forgot. Let me show you something. Let me show you something. Hold on. We have the king of Zoom, Atul Goel, giving a lecture in an hour. And let me punch it up here on the screen. This is where I get a chance to show off screen sharing, Martin.
Yeah, I guess I have to use a different computer. Maybe that fuzziness was.
Okay, here's a tool.
Oh, a tool is coming. Oh, okay.
Yeah, a tool's coming in 1 hour. A Revolution Spine Surgery, a series. He's going to talk about faces of atlantoaxial instability.
Yeah, he's
everyone knows the tool. He's a great lecturer.
Yes, yes.
I'm going to put the information in the chat box right now. Let me get the link. Just give me a second, because I don't want you to go without it. Okay.
Dr. Tseng, so, but this abnormality the wild type was 180 out of 250 patients. So the abnormality of the RNF213 is less than 50% of the Moyamoya patients that you had in your series, right?
Well, in China, we have about 30% Moyamoya disease patients carrying the variant.
Yeah, 30%, yes. Okay.
Yeah.
Okay, everyone, thank you very much, and we'll see you.
Okay, thanks,
next week.
John.
Okay,
Bye
Martin.
for now.
Thanks for
Bye.
coming.
Thank you.
Bye, everybody. Bye,
Thank you.
bye, bye. Thank you.
Gotta have a new computer.
Bye-bye.
No more fuzziness.
That was good.
Bye.
You scared me, Martin.
Yeah, Martin gave a very depthful explanation.